A warm welcome to all of you who have tuned in for this virtual event about our response to the coronavirus pandemic. We here at GMF are delighted to be co-hosting this virtual event with Perry Worldhouse. A special thanks to Professor Michael Horowitz. Let me start with some disappointing news, which is that Dr. Lothar Wieler of the Robert Koch Institute is not able to join us today. He, at the last minute, had another urgent matter arise and had to cancel his participation. But that is paired with the good news that Dr. Ezekiel Emanuel was still delighted to join us for this conversation. And I know that Mike Horowitz and I both look forward to learning from him. We do hope to reschedule a conversation between a German expert on this subject and an American expert, so stay tuned for that. But this morning, we are delighted that you will benefit from hearing from Dr. Emanuel with us. With that, I would like to turn the floor over to Professor Horowitz. Thanks.
Thanks so much. Thanks so much, Karen. We are delighted to be doing this event again with you all today. Welcome to the weekly edition of The World Today from Perry Worldhouse. We're really happy to have everyone here today and to be partnering with the German Marshall Fund yet again. My name is Michael Horowitz. I'm Richard Perry Professor and Director of Perry Worldhouse. And given our slight change of plans that Karen mentioned, today's guest is Dr. Ezekiel Emanuel, who's the University of Pennsylvania's Vice Provost for Global Initiatives, the Diane V.S. Levy and Robert M. Levy University Professor and Chair of the Department of Medical Ethics and Health Policy. From January 2009 to January 2011, he served as a Special Advisor for Health Policy to the Director of the Office of Management and Budget in the White House. He was also Chair of Bioethics at the National Institutes of Health. Zeke, thanks so much for joining us again today for this event with the German Marshall Fund and Perry Worldhouse. And I want to open the floor and turn it over to you to give us some introductory remarks. What's your readout of where we are with regards to the spread of COVID-19 in the United States?
Great, thanks, Mike. Let me make 2 or 3 points. The first point is where we are in the United States. Just a few weeks ago, we were having many hotspots, especially along the South and the West. We had about 67,000 cases, new COVID cases confirmed each day, over 1,000 deaths. We're a little better than that. We're down at 44,000 new cases a day, 850 deaths. So that's progress, and things are getting better. But things are not better enough. We really need to be below 10,000 and even better below 6,000 or 3,000 new cases a day. So there's a lot of room to go. And what I think is even worse news, besides that there's room to go, is how rapidly governors in places like Texas and Georgia want to open up and want to open up exactly the wrong things: bars, nightclubs, indoor spaces where there's crowding for prolonged periods of time, and likely yelling and forced exhalations, all of which we know enhance transmission, all of which we know actually increases the rate of COVID. And one of the things we did badly this summer, I think, was rushing to open indoor dining, indoor bars, indoor activities of all kinds, like tattoo parlors and beauty salons. Those are places where we increase transmission, and during a summer, we should not be doing that. So we're making progress in the US, but instead of going all the way to get our new cases down below 10, down below 6, we're rushing to open. And I think that's going to be a serious mistake and going to come back to haunt us. Second point I would make is you do see an uptick in many parts of Europe, like France and Italy, where summer vacation, people just were abandoning the good measures that they had put in place and kept their transmission rate low, and you're seeing the inevitable bump up. This is part of the roller coaster I predicted in March or April, that as we ease up, we're going to see increases and the need to reimpose some restrictions, especially on indoor activities. The third thing I would comment on is the vaccine. We're seeing a lot of talk about when we're going to have a vaccine, et cetera. I don't know where that talk is coming from. These trials are supposed to be double blind. We don't know who's got the vaccine. We don't know who's getting the placebo vaccine. And for people to say, you know, we're going to have reliable results to release seems to me premature. A lot of it depends upon how people are exposed, how many people come down with COVID symptoms, get tested for COVID. And I think people should not be talking about this. We should just wait for the data, wait for the data safety monitoring boards. It is totally irresponsible for the president, for pharmaceutical companies that are making vaccine to say, oh, we're going to have a vaccine and data by the end of October. That only undermines the public confidence. There is a scientific way of doing this. These are double, as I said, should be double-blind trials that no one should know how many people in each group are being exposed and turning positive. And we shouldn't prejudge when we're going to have enough endpoints. That is that's just up to nature. And for people to say, oh, our models predict we're going to have an answer, you shouldn't really have that information. And you should not be knowing that. And you certainly shouldn't be announcing it as if you're sure and therefore rushing your data out before it's had an opportunity to have independent verification. And that is, I think, quite worrisome to me. And I think, the hesitation you see on the part of the American public about getting a vaccine, I think is directly tied to these announcements which look way premature based upon no evidence.
Well, Dr. Emanuel, thank you. That's a terrific overview. And I know Mike and I are going to want to pick up on various pieces of it. Let me start with your last point about a vaccine and ask you two follow-on questions. We saw this morning that a group of pharmaceutical companies released a pledge that they've made saying they will not release any vaccines that do not follow rigorous efficacy and safety standards, trying to underscore that they will not let this process be politicized. So first question is, what is the significance of that pledge? And then secondly, you recently wrote a thoughtful piece about the ethics of vaccine distribution. And I'd love to draw you out on that. So back to you.
How much time do we have, did you say? So the first question is, look, I think this pledge is the vaccine manufacturers doing a responsible thing. Not all of them have signed on, which is unfortunate, but doing a responsible thing of saying, look, we have standards. They're scientific standards. They're going to be evaluated by data safety monitoring boards that are independent of conducting the trial, that simply look at the data and assess, is there evidence that this is more dangerous and therefore we should stop the trial because people are being harmed? Is there evidence that this is so efficacious we should stop the trial early and release this because the data are overwhelming and there's no chance that they will be reversed given what we know? It's data safety monitoring boards that have to make that call. It's not the principal investigators of the study. They're, as I said, the data safety monitoring boards are independent, and that's really what we want. That the companies have come out and said that suggests that there is a lot of worry in the public, and they recognize their reputation is at stake if they don't adhere to scientific standards and they rush something out. Let me remind the audience something I've said a number of times, and I think they need to keep in mind. This is a race, but the first person to cross the finish line may not be the best. This is not like a 100-yard dash that the first person who crosses is the world's fastest person, right? It may turn out, and it's almost inevitably going to turn out, that the best vaccine, the best in terms of easiest to take, most durable, preventing transmission, is not likely to be the first one. The first one to cross the finish line is the one that's the easiest to manufacture, easiest to get large numbers of, but that doesn't necessarily mean it's the best as a vaccine. And so we are very likely to have a number of results coming out which are going to say, oh, we're better than that, or we look to be better than that one. There won't be head-to-head comparisons, so we'll have to interpret the data. We should also remember that a lot of the vaccine manufacturers are only going to begin starting their phase 3 trial in September. And many of them may have very good models. Of the 9 that have gotten into phase 3 now, the audience should know, only 2 are American, and Moderna and Pfizer. The other ones are either European, AstraZeneca, Oxford, Chinese, or Russian. For the United States, that creates a slight problem. We may not develop the first and the best among the first 9. And I think this is, that Trump has become so nationalistic about this is probably a mistake, since we have no idea how well they're doing. And at least in animal models, certain of them are not as good as others. Whether that translates into humans, only data will show. On the second point, one of the big issues is there are 7.8 billion people in the world. Even under the most rosy optimistic scenario, we might have 1 billion or 2 billion doses of a vaccine by the end of 2021. Much short, only enough to cover 12%, 25% of the world's population. And so we're going to have to make some radical choices about which countries get the vaccine. There's no world government to make that choice, but there are a variety of more haphazard systems. Some of the vaccine manufacturers say they want to distribute their vaccine equitably. What's equitable? Some country prime ministers have said they want to distribute the vaccine equitably. Those prime ministers are led by Justin Trudeau of Canada. They include the Prime Minister of New Zealand. What is fair and equitable for them? The WHO, Gavi, have set up what's called a COVAX facility to buy vaccine and distribute it, especially among low and middle income countries. And they want to do it fairly and equitably. And there's big questions as to what that means. So I pulled together a bunch of public health people, ethicists, political scientists, to try to unpack that. And we just published a paper in Science last Thursday, to actually try to answer that question. And one of the things we said is that you have to, first of all, be future focused, trying to solve or reduce the impact of COVID in the future. And you have to assess how much good is the vaccine going to do in terms of reducing deaths. That's the first goal. Premature deaths, deaths of younger people primarily. How much then economic pain can be relieved, primarily measured by poverty cases and drops in GNI, gross national income, and then distributed to create herd immunity in the whole world. We think that's the right ordering. And just it's a much more complicated argument, as you might imagine, but the last point we emphasize is that other suggestions that we distributed according to population, that 3% of every country, every country get enough vaccine for 3% of its population, that seems like a very unethical and imprudent way to distribute vaccine. We wouldn't take another emergency and say, oh, we're going to distribute our life-saving interventions by population, even to countries that don't seem to have a big threat. And I use this analogy, which I think is a very effective analogy. It's like an emergency room doctor going out into the waiting room said, all right, I got 5 minutes for you, everyone in the room. We don't do that. We say, okay, who's the sickest person? That person with the heart attack, we're addressing them first. The person with the sore throat who's worried about strep throat, you'll wait. That's the way we respond. And we really need to do the same thing when it comes to a vaccine. Places that are really, really hotspots, Brazil, India now, they need the vaccine. Places like New Zealand, Taiwan, yes, they've done a super effective job. Both countries have fewer than 500 total cases of COVID, fewer than 10 deaths. They're down the list. I understand that might seem unfair, but it's actually fair because you're addressing the problem of COVID in the most effective way.
Right. It seems interesting because one might say, like, shouldn't your reward for doing well be that you thus would have access to the vaccine? And you're suggesting in some ways the opposite if one thinks about the global goal of decreasing the number of COVID cases. So I want to follow up with.
And exactly, Michael. So the point is, we don't look backwards. Right. We look forwards.
Right.
How much good can we do with this vaccine? That's the question we need to be asking.
So I want to follow up on this question of when a vaccine would be safe and what it means for the United States. As you've mentioned, President Trump has made a lot of nationalistic arguments about the prospect for a COVID-19 vaccine. Given that, what would it mean if another country gets through phase 3 trials first? And I understand it's not a race, but presume that some other country's vaccine is relatively effective. What does that mean for all of us that are in the United States?
Oh, look, if the Chinese win this race or the Russians win this race, we may be SOL, as they say in among my brothers, right? It could very well be that we don't get the vaccine early and we have to wait and we're down the pecking order. Part of what bothers us and one of the rationales for writing the science paper is, big countries, they have a tendency to want to use a vaccine for power politics as opposed to distributing it ethically. And we emphasize that ethics has to be part of the consideration. We understand that governments have a responsibility to protect the freedom and well-being of their citizens. That will give them rationale for keeping the vaccine in their country, but it's not unlimited. They can't hoard a vaccine. They also can't use it simply for better trade deals or to influence countries. They really need to release it for a fair and equitable distribution around the world. One of the problems that we believe has hampered that idea is the fact that no one defined what fair and equitable meant. And that was part of our goal, is to, here's what fair and equitable means. Here's what the standard we need to hold you to. If you don't have a standard, it's hard to hold countries to that standard. But I do worry that the Chinese government, the Russian government, they might not stick to international standards. The Chinese in particular have chafed. That's a Western standard. It's not an Eastern standard. I don't think our position is a Western standard. It's a universal standard. Limiting harm, ameliorating and mitigating disadvantage, equal concern and respect for human beings. Those aren't Western principles. Those are universal principles. It turns out that everyone in the world wants to have harm limited. They think disadvantaged people ought to be given some priority. And I don't think saying that's a Western standard, first of all, it's not an argument, is really an acceptable approach. And I think we, as many countries have condemned unethical behavior when the US does it, we need to be very, very clear if other countries engage in unethical behavior in the distribution of vaccine, that it's unethical. But, our position in not joining the COVAX facility does put us at a disadvantage if some other country develops the vaccine. There's no doubt about it.
So I have a direct follow-up on the vaccine conversation, and then I have another question for you. On vaccines, I would be very interested to know when you personally would feel comfortable taking being vaccinated. So that's one question. And then one of our listeners wanted to draw you out on what are the right spaces to open up. You began your comment saying that the US is doing a little bit better, but not better enough. And we've opened up too quickly, and we've opened up the wrong things like bars and tattoo parlors. So are the right places to open things like schools? Okay, so when are you willing to be vaccinated, and what's the right way to open up?
Wow. So I'm actually, it'll depend upon you have to look at the data. And if the Data Safety Monitoring Board says, this is effective, first thing. And the second thing is the safety data will be preliminary because it'll only be a few months of safety data. It won't be a year, and it'll be, 15,000 people. It won't be 3 million people, which I think is the kind of number that most vaccine people feel comfortable with saying. And again, it'll be a short time, but I will still take that vaccine. And again, even if you take that vaccine, you won't know how long the immunity will last. The durability, as they say, will be preliminary. But I think if the Data Safety Monitoring Board says, it's past our standard, that would be good enough for me. And I will say I have signed up to participate in trial. I haven't been called, and I, for a lot of reasons, probably won't be called because, you know, I just don't have enough exposure risk in my life. I lead too safe a life, but I would participate in a research trial of this. I think it's, first of all, I think it's an important thing to do. I participate in other research trials, as have my children. So I am willing to take some risk for advancing the science in this case. The second question. So we've published a number of risk indexes, a risk index overall activity and a risk index for school opening. And so the risk index for overall is, you know, outdoor picnics, things that are outdoors where you can space, walking, riding your bike, running, all of those are low risk. Medium risk are things like playing tennis, playing golf, things where, you know, you might run into some other person, you might get within 6 feet of another person without a mask, but that's a rare event. Those are low to medium risk. And then there's a series of things which are medium risk. At the high end, okay, at the high end are contact sports, sports indoors like basketball, travel on public transportation that have, you know, stainless steel poles, people packed in where people are likely, you know, to cough or sneeze. Those concerts where seats are taken, those are the places where those are the highest risk episodes. We've published on schools. Yes, it's more important to open schools than it is to open bars. I mean, I think that's a simple value judgment. I don't think it's a complex value judgment. Schools have enormous value. I understand the appeal of bars, the desire for people to be social, but indoor bars don't have added social benefits of education, socialization of kids, monitoring for their health, giving them meals. Schools have enormous social value and they should take priority. But as we've said, you can only open schools if your, you know, community has a low transmission rate. You can distance kids 6 feet. You can do hand hygiene. Kids will wear masks, or you can have class outdoors. There's a number of things you can need to be able to do to open schools safely. And, you know, most of the United States is not, at least when we published it, wasn't ready to open schools safely. And I think, you know, there's a lot, it's not an easy thing to do. And just to push to open is a big mistake. So for example, one of the things I've suggested, not taken up by places like Wolf Trap or Tanglewood, is outdoor concerts. Great idea. Create circles 6 feet apart, paths so people could walk, and make them outdoors. That works, right? They all canceled their season, which I think was a big mistake. You could have outdoor concerts. Indoor concerts, absolutely not. Bad idea. So I think, you know, we need to be very careful about the judgments of what we open and what we don't open. Are outdoor concerts zero risk? No, but you can make them very low risk. And, you know, if everyone's wearing a mask, you're 6 feet apart, the different groups are 6 feet apart. I think that actually is probably worth the risk. A colleague of Michael and mine at Penn, at the CHOP, the Children's Hospital of Philadelphia, is an expert on infectious disease and vaccines. Paul often says, you know, I'm wearing a mask, you're wearing a mask, and we're 6 feet apart. Really should be almost zero transmission risk between us. And that's important to keep in mind all the time.
So Paul was actually on The World Today last week. We were really excited to have him. You can check it out on the Perry Worldhouse YouTube channel, where he said exactly that. And so Zeke, to follow up, there are a couple of questions in the chat that are basically like, why isn't the US better at this? You know, saying, to paraphrase one of them, you know, says, you know, until there's a vaccine, it seems from other countries, you know, Germany in some ways, obviously, you know, New Zealand, Taiwan, that you can manage the spread of COVID through good social practice. Why is the US not better at this?
I think you just stated it clearly. You can manage it, and you need a government that can manage it. And the Trump administration has proven itself incapable of managing anything. And that is the problem. You know, an effective government can administer programs and can administer, can figure out how to do this. You know, while I'm a physician and a political scientist, I do spend a lot of time reading political history of the United States. And early on in February, I was like, well, how would FDR handle this? And how would Lyndon Johnson, people who knew how to manage the federal government, handle this? And they would have created a whirlwind of task forces and commissions, you know, one on testing, one on PPE, one on ventilators, one on hospital capacity, one on the vaccine, one on treatments. And, you know, they would have had 20 of these things, all with super competent people. And yeah, would it have been slightly inefficient? You bet. Would it have been way better managed, and would they have addressed all of the problems that we need to have addressed? Absolutely. And that's the difference. You know, we've had a task force that, you know, when you have a problem, what does the president do? Jared will manage that. Well, Jared did a fantastic job on testing, really solved. We have fewer tests today. We hit a peak at 800,000 and now we're down in the 700,000s when we should be at 5, 6, 7, 10 million tests a day. You know, that's just bad management. You could manage this much, much better. And countries that have done better have done a better job of management. And remember, part of good management, communication to the public, simple messages, 6 feet apart, right? Wear a mask, do hand hygiene, isolate yourself if you're feeling bad and get that COVID test, making COVID tests easy. You know, those are the simple things. And we just have been incapable of doing that because the federal government has been incapable of managing this program. You know, you've got to actually take the Wharton management classes seriously, but not this government. And I think it really does boil down to that. This is not rocket science. It's not sending a man to the moon. It's managing. And the irony, of course, is, you know, the United States is in some ways the best place in the world for management and logistics, right? We've got the Defense Department that really knows logistics incredibly well. We've got Amazon, UPS, FedEx, lots of other companies that really know logistics well and that can manage. And yet we have a federal government that doesn't have those kind of people in it and hasn't seen to draw them in to the process to help us manage this calamity.
So let me follow up on that and ask you to keep your comparative lens on, because you also mentioned in your opening comments that we're seeing an uptick in Europe, that as Europeans are returning from vacation, we're seeing those cases increase. And you mentioned in particular France, Italy, we're seeing it in Spain, we're seeing it across the continent. So do you see that those European countries have learned something over the past several months and are managing this differently? Sort of that trilogy of testing, tracing, and isolating is working more effectively in Europe. And you know, your comment that the federal government here hasn't been seen as being as effective in managing the pandemic. Are you seeing any positive examples at the state level in the US? But just help us understand. Yeah, okay.
So first of all, absolutely. The European countries, they got hit very early on, you know, 1 or 2 weeks ahead of the United States, when we didn't know really what to do. Hospitals, especially in Italy, were overrun, but they instituted all the measures suggested. Closing of non-essential businesses, lockdown, real penalties if you were caught outside or driving around and not where you were supposed to be. Then when masks became clear, instituting mask mandates. And you could see from the sort of peak, you know, early in March, in the first 2 weeks of March, down to the end of May. So absolutely down to the bottom where transmission went, or new cases went, you know, 2 or 3 per 100,000 population. And then they stayed that way for the whole summer. Look at Italy, look at France, go to the various websites that record this. And only in the sort of mid to end of August do you see this uptick corresponding to summer vacation, going to play on the beach, taking your mask off, going to bars, etc. And I think that's that's better management. Look at Greece, of all places. Greece did a great job. They have a rickety healthcare system, so the government was very strong. They couldn't overwhelm the healthcare system. They really pushed these public health measures and had a really, really surprisingly effective response that I think has been better than many of their European neighbors. So we do know that you can actually respond, and that response makes a difference, both in terms of reducing number of cases and, most importantly, saving lives. As I said before, I predicted that as you open up, or in this case, go on summer vacation, you will have an uptick. You will have the roller coaster. You will go back up. But then, because you're at a very low level, it's easier to suppress. It's easier to identify the cases, keep them indoors for 14 days, do contact tracing. If you start out with 44,000 new cases, you go up to 66,000, there's no chance of suppression and contact tracing, and you're just gonna have another explosion and have to wait more time. And let me just finish. This is very predictable. You see this 8-10 week period from peak to trough. If you follow these measures, it's very predictable that that's the amount of time you need. Here we are in the United States, and we cannot be consistent. So is there any place domestically that's done well? Yeah, look at New York. Cuomo has done and it's not just New York, Connecticut, New Jersey, all the places have done a reasonably good job. I would fault them a little bit. Some of the states opened up, whether it's indoor dining, indoor bars, casinos, other combinations, which I think should be way at the end, months and months from now. And, I understand the rationale. These are often small family businesses. They need it's the summer. Let dining outside and only dining outside separated. That's what we should, no bars. I'm sorry about bars, but, they have all the combinations that increase transmission. And getting down to a very low level is really important for things like opening schools. And it also makes interventions when you do have an uptick much easier to do when you have just a few cases as opposed to thousands of cases. But we did, there are parts of the country that have done a really good job. And we can see in the declines in places like Arizona, even Georgia and Texas, public health measures work. Wearing a mask, it works. You got to stick to it, though, for more than a few weeks. You have, 8 to 12 weeks and being very rigorous about it. And the first good sign doesn't mean you ease up. That's the mistake that's being made.
So we'd love to get your opinion in this, from the Q&A about another thing people have talked about as a way to decrease transmission, and that is the potential availability of rapid test kits, home testing kits, these sort of, $1 to $5, get results in 15 minutes. They're not going to be that accurate, but they might help with sort of mass testing. Is this a good idea? Well, one, is this going to happen? And two, is this a good idea?
It's going to happen when I think is a little, I think in May or June, one of the investors in one of these companies, had me talk to the CEOs and the scientists there. Yeah. Promising, but it takes time. And in particular, the sensitivity and specificity were not there, and they've had to try to adjust the tests to get them better, right? I mean, the biggest disaster that could happen is you get a lot of false negatives, right? You get tested, you have COVID, but it says you're negative. That would be a disaster. So we let you into the restaurant, we let you into public places, you don't wear a mask. That would be a disaster. And so these tests have to be good, and in particular, few false negatives. And they're just not there yet. But the bigger problem is, say it works, okay? Now people are going to want to test themselves. You're going to need billions and billions, going from zero to manufacturing 1 billion, 2 billion, 10 billion. I think that's the pipe dream that people have. In
right, like
normal
the home pregnancy test equivalent of a COVID test, basically.
Well, no, way more than the home pregnancy test. You don't have billions used every day or every few days in the United States. This you're going to have, I want to be tested every day. Well, that ain't going to happen. I want to be tested every week. All right, that's 330 million tests every week. In a month, Michael, you can do the math. That's over 1.2 billion, right? Manufacturing going from 0 to 1.2 billion in a month, nah, not happening. Okay,
Right.
and I think people haven't gotten their heads into this. You know, these are big challenges. These are the kind of things that the federal government needs to think about. And then, so if we're not going to be able to get everyone a test, how do we distribute it so we make the most effective use of the test? And you know, if you had a federal government using the Defense Authorization Act, that's what you would be doing, thinking about it and also distributing it. You know, going back to our issue about management, one of the things we noticed is even when the federal government under Trump tried to do a good job, get PPE and distribute it, they did a terrible job, right? They sent too much PPE to small hospitals that didn't need it and that were no longer hotspots, not enough to other hospitals. That's exactly the kind of thing that, you know, good management would not have done.
So I think everybody wants to know, when can our lives go back to normal? And that's why we're also fascinated by the vaccine and when a vaccine will be available. But the other alternative is that effective treatments are developed to manage COVID-19. So A, I want to draw you out on whether there are effective treatments being developed. And then B, we have one of our questioners asking what this tells us about healthcare systems. And is part of the issue in the United States that we don't have universal coverage. And this questioner is saying, aren't we seeing countries like New Zealand, Germany, Italy that have universal healthcare doing better in response? So effective treatments, and what does this tell us about healthcare systems?
So there's one super effective treatment for very sick patients. That's dexamethasone, this low-cost steroid that's been around for decades. The British showed that it was positive months ago, and then we just last week, I believe, JAMA published a number of confirmatory trials. So dexamethasone, remdesivir is out there. It's produced by Gilead. It's, you know, all it's proven to do is decrease the time you're in the hospital from 15 days to 11 days, roughly. Hasn't been shown to statistically improve survival. The trial we did wasn't big enough to show that. There was a trend, but not evidence of that. So that's our armamentarium. It's much harder to develop an armamentarium. The quick and dirty treatments, so we're developing a bunch of monoclonals. Those are going to be expensive to produce, limited quantities. The funny thing is they're easy to produce in small quantities to do clinical trials. They're hard to produce in mass quantities to treat lots of people. But what you really want is something where you get infected, it prevents serious infection that you can have early on, or you could take instead of a vaccine to prevent, right? You could have a preventative treatment like PrEP for HIV. We don't have a vaccine for HIV, but we have PrEP that really decreases getting HIV if you get exposed. Those are going to take a lot longer to develop, and they're not going to be developed instantaneously, but they could be very effective interventions. And mostly, as we understand, for viruses, one drug isn't enough because viruses can mutate, or so you typically need 2 or 3 drugs combined. We have that for HIV. We have that for a number of other viral infections like hepatitis C. And I suspect that for this, we're probably going to need something like that. And again, long ago in April, I said, you know, it's not going to be one drug. Taking off the shelf drugs is probably not going to be super effective. To get drugs that are really effective and easy, you know, that are like pills, that's a whole drug development process, and it's going to be years, not weeks.
So,
you know, we don't like to hear that. So your last question there, Karen, is when are we going to return to normal? We're going to return to normal, as I keep saying, November 2021.
so
And I'm sticking to that date.
brutal. We want to.
I know. Look, Michael, I think I've told you. I had 4 international trips this summer, and you know, Taiwan, Switzerland, Israel, and then Portugal, and for conferences as well as other activities. I feel as bad as everyone. I don't say November 2021 because I like inflicting pain. I'm an optimist. I'm a person who, let's do it. Let's take some risk. But we're not going to be able to have a vaccine and have it sufficiently widely distributed. And this assumes we're going to get a vaccine relatively soon, i.e., around the turn of the year. But to get it into enough people's arms and to get it internationally, that's going to take time. And I think, we can't really return to normal before that. And as New Zealand has shown, you open up, you get some cases, and we've got to be, we're going to have to be really careful about this.
So we want to get you out of here a little bit early. And so let me ask you a last question that actually, here, I'll give you a New Zealand hook for it, since that's where you ended. One of the things, as an avid sports fan, one of the things I was super jealous about was the, return of sports and, fans in stadiums, even briefly in New Zealand. And we have a question in the Q&A that asks, can we learn anything about the experience of sports and testing? That the NBA's rapid test is being considered for broader use, but the NFL's test has generated a lot of false positives. Is there a potential model here from some of the testing regimes that professional sports leagues are using, or is that kind of a one-off?
Well, again, early on, I thought getting sports back was really important to giving people a sense that we could get back to normal.
It makes me happy.
Yeah, well, I'm not a big sports fan, as you know. I like to do sports, but I don't like to watch sports that much. But I thought it was really important to get sports back up. And I did advise the WNBA about creating a bubble and putting people in a bubble and getting people to adhere to a bubble, that was probably going to be the best way to get sports back without fans in the stadium. I thought it was, the NBA, I think, is 2,000 plus people. It's harder, but they're doing it. And it's obvious that they've been able to very carefully open up and have a reasonable regime, and actually have the players adhere to a reasonable bubble regime. And by the way, we do some advice to the entertainment industry and getting movies and TV production back up. And, if you can do a bubble, that's a very good thing. It does create challenges getting people into the bubble, making sure they're tested sufficiently, and repeated testing. So we can learn something from those kind of bubbles. Problem is, you can't create a bubble of 330 million people. But by the way, it's not only sports. You saw this in the camps in Maine, right? Where they brought kids together. They instituted all the safety precautions: hand hygiene, masks, distance, outdoors, ventilation. And in Maine, they had, I think, no cases. So you can do it. You got to adhere to the safety precautions. And for some reason, we can't get it through to many governors and the federal government that this is really the path forward. It's the path forward to opening up safely. It's the path forward before we have a vaccine widely distributed. And again, that's going to be till next year, because you're not, even if you get a vaccine on January 1st, you're not by January 30th going to have 300 million or even 250 million Americans vaccinated. So we're going to have to do these things for a long time yet. And I think educating the public, getting them ready for this is critical to getting compliance and making the country as safe as possible.
Well, speaking of bubbles, I think that Mike and I and everyone who tuned in for this virtual event is delighted to be in that virtual bubble with you, Dr. Emanuel, because you are illuminating as always. An enormous thanks to you for spending this time with us. And to all of you who are listening in, thank you for the fantastic questions. Dr. Emanuel said, I'm happy to do this because the audience always asks the best questions. So
absolutely.
I'm sorry that we couldn't get more of them in. Mike and I tried to weave in as many as we could, but thank you all for joining us too. And with that, let me hand the baton back to Mike.
Thanks again, Zeke, for those insights, and to Karen, you and your team at the German Marshall Fund of the U.S. for working with us on another great event. Thanks everybody for joining us. And from a Perry Worldhouse perspective, we hope to see you next week when we have 3 exciting events on the climate emergency and human displacement, featuring the former president of Kiribati, Anote Tong, on Monday, former US Secretary of Defense Chuck Hagel on Tuesday, and the current head of the UN Climate Change Secretariat, Patricia Espinosa, on Wednesday. You can find out all about that at our website just by Googling us or by following us on Twitter, Instagram, at Perry Worldhouse, and check out our YouTube channel and the German Marshall Fund's YouTube channel for this event and a lot more. Thanks a lot, everybody.
Thank you, Mike and Karen. Really appreciate it.
Bye-bye. Thank you.